carbon, hydrogen, nitrogen and hydrogen, sulfur and oxygen, nitrogen and hydrogen. Para-amino, benzene, sulphonamide, and certain derivatives of it are the sulphonamides used in medicine. These derivatives are formed by substitution of amino or amide hydrogen. The first one to be used clinically was a sulphonamide derivative of a dyestuff, chrysoidin. Domark announced this to be curative in experimental streptococcal infections, though virtually inactive in vitro. French workers suggested this was due to sulphonamidochryssoidine being broken down in the body, with release of the active para-aminobenzene sulphonamide, commonly known as sulphonilamide, which now largely replaced the dyestuff compound in clinical use. Since sulphonilamide proved to be inactive against pneumococcal infections, efforts were made in the May and Baker research laboratories to find a sulphonamide which would be effective in the treatment of pneumonia. Many compounds were synthesized and tested. Of these, a heterocyclic derivative of sulphonilamide, 2-para-aminobenzene sulphonamidopyridine, was found to be active in experimental pneumococcal infections and of low toxicity. The properties of this compound, which had been given the laboratory number T693 by the discoverers Ewins and Phillips, were reported in the Lancet for May the 28th, 1938. A controlled clinical trial in acute primary pneumonia was made. The results of this trial were reported in the Lancet for July the 2nd, 1938. Results of further trials in pneumonia and information regarding possible toxic effects were collected. These being satisfactory, the drug was generally released. Studies in a wider clinical field were made, including the treatment of gonococcal and meningococcal infections. Soon, the demand for the drug was worldwide. In view of the imminence of war, the discovery that an effective and relatively safe chemotherapeutic agent was available for the treatment of gonorrhea was to prove extremely opportune. Meanwhile, investigations in the May and Baker research laboratories had been continuing. Because of the established value of M&B 693, which was later to be termed sulfapyridine, attention had naturally been directed to further compounds of similar chemical constitution. The next heterocyclic derivative to be synthesized was the corresponding thiazole compound, which was designated M&B 760, later termed sulfathiazole. This compound was also discovered independently by Swiss workers. These achievements stimulated energetic research in other countries, notably in the United States, where further heterocyclic derivatives were synthesized during the early years of the war. Important contributions to the pharmacology of these compounds were also made. Sulphonamides inhibit the multiplication of susceptible organisms, provided the drug is present in sufficient concentration for a long enough time. This inhibitory action is reduced or abolished by purulent exudates. The bacteriostatic action of sulphonilamide and its derivatives is also inhibited by para-aminobenzoic acid, which is closely related in structure to sulphonilamide. One theory of sulphonamide bacteriostasis, which does not, however, fit all the known facts, is that para-aminobenzoic acid is an essential metabolite for certain bacteria, and that sulphonamides compete with it. Sulphonamide-sensitive organisms are those unable to synthesize sufficient para-aminobenzoic acid. Sulphonamide-insensitive organisms are those able to do so. The amount of para-aminobenzoic acid required to antagonize the bacteriostatic action of different sulphonamides is an index of their activity. While the sulphonamides have little specificity on bacterial species, they differ in degree of activity. Sulphonamide resistance can develop as a result of the use of suboptimal concentrations. But this does not imply resistance to a different antibacterial substance, such as penicillin. The presence of the drug in normal concentrations does not interfere with phagocytosis and other body defense mechanisms. If the natural defenses are unequal to their task, an infection may prove fatal despite the correct use of sulphonamide therapy. In man and most animals, sulphonamides are partly conjugated to an acetyl derivative. This takes place mainly in the liver. The acetyl derivatives are inactive, since for full activity, a sulphonamide must have a free or unsubstituted amino group. Sulphonamides penetrate to all body fluids in varying degrees, including the blood and tissue fluids, cerebrospinal fluid, and the milk, which has no untoward effect on the infant. They also pass into the fetal circulation without ill effect on the fetus. After absorption, sulphonamides are excreted almost entirely by the kidney, partly unchanged and partly as acetyl derivatives. With these sulphonamides, the extent of absorption from the intestinal tract after oral administration is only about 5% of the amount ingested. While succinyl and thionyl sulfathiazole are virtually inactive in vitro, they are active in the intestinal tract, this being ascribed to the partial hydrolysis they undergo. Hydrolysis to free sulfathiazole takes place too low in the intestinal tract for much absorption to occur. For this reason, the succinyl sulfathiazole and thionyl sulfathiazole are the sulphonamides of choice in intestinal infections. Sulphonamides are used in the treatment of acute infections by the pyogenic cocci. Sulphonamides also have an action on some gram-positive bacilli. They have been used, for example, associated with antitoxin and surgery, in the treatment of gas gangrene. They tend to be less active on gram-negative bacilli, but are, however, effective in chancroid due to Haemophilus ducreyi, in urinary tract infections due to Bacterium coli, and acute bacillary dysentery. Sulphonamides have a retarding influence on the course of experimental tuberculous infections in guinea pigs when they're given in very large doses. They are, however, of no value for the treatment of human tuberculous infections. The compound 4,4-diaminodiphenyl sulfone is a more active antibacterial agent than the sulphonamides, but it is too toxic for clinical use. Various derivatives of this compound have been found to be more effective than sulphonamides in experimental tuberculous infections. These sulfones have been used clinically in the treatment of tuberculosis, both systemically and by topical application to accessible lesions. The results on the whole have been disappointing, and the sulfones are rather toxic, though research is still proceeding. Trials of the sulfones in leprosy have given much more promising results. These compounds are proving effective in the lepromatous type of leprosy and in arresting eye damage. Sulphonamides are most effective in infections running an acute course, which tend to be generalized. Successful therapy aims at a high loading dose, followed by smaller doses at regular, frequent intervals to maintain the blood concentration at a constant level. No attempt should be made to obtain a higher blood level by restricting fluid intake. 4 to 6 pints per day are essential. The following tables of dosage are given as a guide to assist clinicians in judging the appropriate dose for an individual patient. There are a number of variable factors which influence dosage. While sulphonamides are primarily indicated in infections running an acute course, they are also of value in subacute types of infection and may have a place in the management of certain chronic infections and conditions of infective origin. For example, in bacterium coli infections of the urinary tract, sulphonamides are frequently effective in clearing up any acute and subacute attacks. In chronic bacilluria, however, it may not be possible to eradicate the infection permanently in the absence of any discoverable underlying pathology. But a very small dose of a sulphonamide taken daily or on alternate days for long periods will usually keep the urine sterile. In some chronic dermatoses, courses of sulphonamides in small dosage may be useful, notably in dermatitis herpetiformis, where the distressing symptoms are often relieved in a striking manner. Sulfapyridine is the compound usually advised, as it will sometimes control the disease when other sulphonamides fail. The reason for the superiority of sulfapyridine is not known. Sulphonamides have some prophylactic applications. The dosage required for these is much less than that employed in active treatment. Examples of prophylaxis in surgical cases include prevention of urinary tract infection, as in patients with an indwelling catheter, and obstetric cases of a kind in which infection is liable to occur, such as prolonged and instrumental deliveries. Examples of medical cases include the control of secondary bacterial infections in such conditions as measles, pertussis, and influenza. The prevention of acute rheumatism after tonsillectomy and the prevention of recurrences in patients, especially children, who have had an attack of rheumatic fever, has been widely studied. The abnormally lengthened PR interval on the electrocardiogram indicates rheumatic carditis. For the prevention of acute rheumatism, the sulphonamide is administered for several months. Sulphonilamide was the compound originally used, but it has been largely replaced by the heterocyclic derivatives. Sulfamerazine is perhaps the drug of choice, since the infrequent administration is an advantage in these cases. Group prophylaxis is the systematic administration of a sulphonamide to control the spread of an infection in a community. Examples are the control of epidemics of cerebrospinal fever, tonsillitis and respiratory infections, and bacillary dysentery. For the control of bacillary dysentery in mental hospitals and other institutions, a small dosage of succinyl sulfathiazole or phthalal sulfathiazole is effective and virtually free from risk. Sulphonamides are used topically as well as systemically. For the local treatment and prevention of accessible infections, they are applied in the form of powders, as various types of ointments, and in solution. Solutions of sodium sulfosetamide are sometimes used because they are neutral in reaction. The value of sulphonamides for these purposes is limited by the inhibitory effect of pus on their bacteriostatic action, by their lack of effect on gram-negative bacilli, and by the risk of local sensitization. For these reasons, better results are generally to be obtained from the use of one of the aromatic diamidines or of penicillin. Sulfaguanidine, of which about 30% to 60% is absorbed, was introduced for the treatment of bacillary dysentery. Succinyl sulfathiazole and phthalal sulfathiazole, with both of which absorption is about 5% only, are now largely used for this purpose. The two latter sulphonamides are also used in surgery of the intestinal tract, both before and after operation, for the prophylaxis and treatment of peritonitis, fecal fistulae and wound infection of patients undergoing such operations as resection of the rectum and of the colon. The operation, the stages of which we see here, for resection in cases of carcinoma of the colon, carries a risk of peritonitis, the mortality from which has been reduced by the use of these gut-active sulphonamides. For this purpose, phthalal sulfathiazole is advised. It is essential to use a very large dosage. Some surgeons use as much as 4 grams 4-hourly for the first 24 hours. A reduced dosage must be continued for several days after the operation. Trial of phthalal sulfathiazole is justified in ulcerative colitis, both acute and chronic. While the results of treatment are difficult to assess in this disease, phthalal sulfathiazole appears to give better results than any other sulphonamide. Though emetine is the standard specific for acute amoebic dysentery, succinyl sulfathiazole or phthalal sulfathiazole are used to control the secondary bacterial infections. While this use of sulphonamides is adjuvant to specific therapy, they are employed in veterinary medicine as the primary therapeutic measure in certain infections by coccidia, as well as in various bacterial infections. For oral administration, which is the routine method, the tablets should be crushed up to aid absorption. They may be taken with water or milk. About 20 grains each of sodium citrate and sodium bicarbonate may be added. This will alkalinize the urine and so render the sulphonamides and their acetyl derivatives more soluble. The mouth should afterwards be rinsed and the water swallowed, as the powder tends to lodge in the buccal cavities. In comatose states, the drug may be given by nasal catheter or stomach tube. But parenteral administration is generally to be preferred when oral administration is inadvisable or difficult, for instance because of vomiting. In severe infections, all or part of the initial dose should be given parenterally, maintenance therapy being oral. Intravenous injection is the method of choice. The intramuscular route provides an alternative. For parenteral administration, the sodium salts of the sulphonamides are used. These yield solutions which are strongly alkaline and should never be given subcutaneously or intrathecally. If the sodium sulphonamide is in the form of powder, this is dissolved in the appropriate volume of sterile distilled water. Sodium salts of sulphonamides are often supplied in the form of concentrated solutions of 25% or 33 1/3%. And for intravenous injection, it is essential that such solutions should be diluted to a concentration of from 5% to not more than 10%. Stronger solutions would be more irritating should perivascular injection or leakage occur. If the intramuscular route is used, the injection must be deep. The deltoid is not the most suitable. Cases of wrist drop have occurred from damage to the musculospiral nerve. Foot drop has resulted from damage to the sciatic nerve, so that an intragluteal injection must be given in the upper outer quadrant of the buttock. The vastus externus provides a very suitable site for intramuscular injections, which is free from any danger of nerve injury. For intramuscular injections, the concentrated solution of 33 1/3% or 25% is used. When parenteral administration has to be continued, repeated injections can be used, but sodium sulphonamides may be added to the intravenous drip for patients receiving infusions of saline or dextrose. The disadvantages and potential dangers of the alkaline sodium sulphonamides can be avoided by giving soluthiazole. This is a neutral soluble derivative of sulfathiazole. Intravenous doses of from 5 milliliters to 25 milliliters may be given. These correspond to 1 to 5 grams of sulfathiazole. Doses of 5 milliliters may also be given intramuscularly and are very well tolerated. Cyanosis was one of the first side effects observed in the early days of sulphonamide therapy. It was found to be associated with the formation of sulfhemoglobin, or of methemoglobin. Cyanosis is mild and infrequent with the modern heterocyclic derivatives, and when it occurs is due to methemoglobinemia. Vomiting when it occurs is central and not local in origin. This, together with various cerebral symptoms, is most common with sulfapyridine, less so with sulfathiazole, and relatively infrequent with sulfadiazine and its methyl derivatives. Sulphonamide rashes are usually due to the development of sensitization to the drug and may appear on about the 9th day. They may be preceded by drug fever. This is one reason why sulphonamide therapy, topical or systemic, is preferably limited to about 5 days. If a patient has previously become sensitized, instead of occurring on about the 9th day, the rash may appear at once. Various forms of blood dyscrasia have occurred during sulphonamide treatment, and most of these also appear to be sensitization phenomena. An early leukopenia, unless rapidly progressive, is of little significance. In the rare cases where prolonged administration is necessary, frequent white cell counts should be carried out. Acute hemolytic anemia is a rare complication of sulphonamide therapy which appears early. Other, even rarer complications being aplastic anemia and purpura. The occurrence of hematuria usually indicates the deposition of crystals in the urinary tract, the signs and symptoms of which include lumbar or abdominal pain, oliguria, and macroscopic hematuria. The treatment at this stage is withdrawal of the drug and the forcing of fluids. But should the condition proceed to complete anuria, cystoscopy and ureteric catheterization will usually be required. The possibility of crystal urea, which may occur with any of the absorbed heterocyclic derivatives, is reduced by the maintenance of a high fluid intake and an alkaline urine. If in a saturated solution of a sulphonamide another is dissolved, their solubilities are not decreased. Addition of a further quantity of the same sulphonamide would produce a supersaturated solution from which sudden crystallization may occur. This principle of mixed sulphonamides may be utilized to reduce the risk of crystal urea. Investigations have shown that an appropriate mixture is one of sulfathiazole, sulfadiazine, and sulfamerazine in approximately equal proportions. This is issued for oral administration under the name sulfatriad. Today, the scope of antibacterial therapy is extended by certain antibiotics. In some infections in which sulphonamide proved inadequate or ineffective, penicillin has triumphed. Streptomycin has proved valuable, and the search for new antibacterial agents goes on. Sulphonamide therapy, however, constituted the most important advance ever made in therapeutics and inaugurated a new era in the conquest of disease.